Hi everyone, and welcome back. My name is Tiaza Arianto. I'm a medical doctor and a cancer biologist. Thanks for tuning in to Medical Conversation. So this time I'm doing something a bit different. I'm recording this in a video format, which later I'm going to upload to my Instagram, probably YouTube, let's see. But I also upload the audio to my podcast on different platforms, wherever you listen to your podcast. And today I want to do something a little bit different. This is probably going to be a running theme, which I'm going to do like several episodes using different cases, different scenarios. But it's a deep dive into how clinical trials, how the big studies can sometimes trick us or even deceive us. And what we, as doctors, researchers, scientists, need to sharpen our critical thinking. Now, for this first episode, let me set some expectations. So this episode will probably resonate most with practicing GPs, residents or senior attending, even doctors who deal with evidence-based decisions every day. But as always, medical students and even people outside medicine are welcome too. So some technical terms will pop up, but don't worry, the big picture themes are universal. It's about truth, trust, evidence, and responsibility. So let me start with something a bit personal. When I was in training, medical school, life was hectic, The schedules were brutal, long ward rounds, endless list of things to do, sleepless nights. By the time I got a rare free evening, maybe golden weekend, free time, 3 days, I didn't want to spend it buried in statistic or trial methodology, reading extra books, extra papers. I wanted to just sleep, see friends, maybe take a short break with families and loved ones. And I think because of that, like most of us, I learned to follow instructions. So, our seniors, our consultants say, order the scan, the guideline says, prescribe this drug. Our institution says, follow this protocol. And so we did. But rarely did we stop to ask why. Why this drug? Why this threshold? Why this period? Why this protocol? And the answers that I got were usually just because that's what we do, quote unquote. But here's the shift. Once we graduate, everything changes, right? Because every decision that we make, every order, every scan, every conversation with a patient, it becomes our responsibility. We can't just shrug it and say, oh, the guideline told me so. Patients trust you to think for yourself. And here's the good news. You don't need to be at, prestigious institutions or have like hundreds of publications and H-index to think critically. It's not elitist. It's not optional. It is a basic duty for every scientist. In fact, sometimes experts are more vulnerable to tunnel vision, to career pressures, to external influences. Sometimes the clearest questions come from the resident, the student, the GP, or the community practitioners who still sees the patient as a whole person and not just, a goal in a trial. So let's turn to our case for today. I want to talk about code break 200 of Sotorasib. For a background, we all know lung cancer. It is one of the biggest cancer killers worldwide. Most cases are non-small cell lung cancer or NSCLC. Over the past 2 decades, we've learned that NSCLC isn't just one disease. It's many different diseases driven by different mutations. That's why targeted therapies like EGFR, ALK inhibitors have changed outcomes for many patients. And one of its driver mutations called KRAS, one of the most common mutations in NSCLC, and for decades it was considered undruggable. Once you read about KRAS, you'll see this a lot, that people said, oh, it was once thought undruggable. And its particular subtype called KRAS G12C finally gave scientists an opening. So this mutation, particular mutation, it's around 13 to 14% of NSCLC patients have it. And the breakthrough was realizing that this mutation created a tiny chemical handle that could be attacked by a drug, in a simple term. So that's how a drug called Sotorasib was born. The first pill that could hit KRAS G12C. Or the hype was enormous, let me tell you. And after all, we're talking about cracking one of oncology's biggest frustrations, and people lauded it. People were celebrating. It was its own thing. But the CodeBreak 200 trial was meant to prove that Sotorasib works. It compared the drug against a conventional chemotherapy called docetaxel in patients who had already failed chemo and immunotherapy. I'm going to talk a little bit more about this, or why we do this in second line, not first line. But the primary endpoint was progression-free survival, or PFS. It's measured with RECIST criteria. It's on scans, so we see whether the tumor progresses on scans or not. If patients drop out or were lost to follow-up, or the data was censored, or if they die, it also triggers the PFS. The secondary endpoint is called overall survival. So it's really easy. It's just whether a patient dies or lives. It's pretty straightforward. And the results, so PFS, progression-free survival, was 5.6 months on Sotorasib versus 4.5 months on docetaxel. In another way, you could say that, so in the Sotorasib arm, the patients were free from disease progression for around 5.6 months compared to 4.5 months on chemotherapy. So if you notice, that's only a difference of 1.1 month, around 5 weeks. And the hazard ratio looked good at 0.66. And if I remember correctly, the response rate for Sotorasib was high too. It's around 28% versus 13% on docetaxel. But overall survival, the thing whether the patient lives or dies, there was no difference. In fact, numerically, it was worse. It's 10.6 months survival with Sotorasib versus 11.3 months with docetaxel. And that's not statistically significant. So the thing is, for, I don't know, around $15,000 or $17,000 a month drug, that's a bitter pill to swallow, no pun intended, because it can't even beat the old grandpa chemotherapy of docetaxel, can't even beat that. And there are some trial design problems with Sotorasib. So the first problem is the comparator. So patients on the control arm just got docetaxel. But by the time the CodeBreak 200 trial was running, we already had stronger options. So even by 2014, we already knew that from Revel trial and LUM-LUNG-1, they have shown that docetaxel plus ramucirumab or docetaxel plus nintedanib, another drug, helped improve survival. So they even had better OS, which in this case, CodeBreak 200 Sotorasib couldn't even do versus docetaxel. So in oncology, the norm is to compare against the best available care. That's how you prove value. Using an outdated comparator stacks the deck. So I think the analogy is like if you have a new shiny car, right, and you're boasting it, it's amazing, but it only beats like a 1990s sedans or hatchbacks SUVs in a race, while you're ignoring the modern electric cars on the road. So of course you beat it, but it doesn't prove anything, right? Second problem is called crossover. So patients on docetaxel in this trial were allowed to switch to Sotorasib, the experimental drug, once they progressed. And can you see why is it a problem? So crossover can make sense in some trials. For example, when a drug is already proven in later lines and you're testing it testing it earlier. And the question is timing, and ethically, you don't want to deny patients access. But in CodeBreak 200, Sotorasib was brand new. It is an experimental drug. It was. And the whole point was to prove if it actually helped people live longer. That's why we tested it on second line, not first line. If you let the control group switch, both arms eventually get Sotorasib. So the intervention arm got Sotorasib in the first place, but the control arm, docetaxel, when they progress, they allowed it for those patients to switch to Sotorasib. And if survival looks the same, you can't tell if it's because the drug works or because it doesn't. It muddies the water. So the analogy that I can think of is you can imagine a race between two runners. So halfway through, you let the slower runner hop onto the same track as the faster one. If they finish at the same time, how can you tell who is really faster? Now, regulators know crossover muddies the water, so they use statistical tools. They could use something like RPS-FTM or IPCW to adjust survival data. I won't go into the math too deep, but just know that even after these corrections, the FDA found no survival benefit for Sotorasib. And the third problem was about sample size and power. So power is like resolution in a photograph. The fewer pixels, the blurrier the picture. If you shrink the sample, you lose the ability to see real differences. So the original protocol was planned for this trial to enroll 650 patients. And that was powered, had enough power to test for overall survival. And midway, it was cut in half, 330 patients. And it became only powered for PFS, not OS. So you can imagine if you flip a coin, if you flip it twice and get two heads, you might think the coin is rigged because you flip it twice, you get two heads. Should be 50-50, right? But it's because you don't have enough data. If you flip it 100 times, you flip it 1,000 times, the truth emerges. It becomes 50-50 or at least close to it. That's what sample size does for trials. So by shrinking the CodeBreak 200, the authors, the sponsors, the defenders could later excuse the negative OS result by saying, well, the study wasn't powered for OS anyway. That's circular reasoning. And to prove non-inferiority properly, based on a calculation done by a team, for HR up to 1.3, you would actually need about 2,000 patients to prove that Sotorasib has non-inferior overall survival over docetaxel. Because the OS of both weren't different, and there wasn't any statistical significant difference, you couldn't say that it was non-inferior. You need a whole other statistical approach to prove that. So with 330 sample size, that claim isn't credible. And the fourth is open label design. So, open label, everyone knew which drug a patient was getting. The patient, the doctors, the team, they knew. And many patients on docetaxel actually drop out early. I mean, that's really understandable because I know I would. If you go into a trial, you get randomized and you find out that you are allocated to an arm that is inferior, it's only docetaxel, when you know out there was a regimen, docetaxel plus ramucirumab, for example, that could improve your survival. Why would you want to stay in that arm, right? So in oncology, open label trials are common, but you need safeguards to keep follow-up equal. Without that, it imbalances the results. So, easy analogy, it's like we're running a blind test between Coke and Pepsi, two sodas. But you can see which glass has Coke in it, which glass has Pepsi in it. Of course, you already have a bias in your mind, which one is tastier, which one's your preference, and that's just, that's not good. So we know that now Sotorasib is already approved in many countries, many areas. The United States, FDA, in the EU by the EMA, and the UK by NICE. So even with all these problems, it still got approved, and I see it as a failure of a regulatory process. Although the FDA actually ran an independent analysis, their own probes to the problems that this trial Codebreak 200 was having. So the first was interval censoring. So the trial assumed progression always happened at the scan, right? In the protocol, it was specified that you have a scan every 6 weeks. But progression could happen within that waiting period. For example, if you are a patient in this trial, so in your first visit, you got scanned and there's no progression. And then you wait for 6 weeks, and your second visit, you are scanned, and now there is progression. But that doesn't necessarily mean that your tumor actually grows on that 6th week. It could have happened between this waiting period. So by pushing every event to the end, to the 6th week, 6th, 12th, 18th, you inflate the PFS. It's like checking your mailbox weekly, and you assume that the bill arrived on Friday, not Monday. But while you're not checking, the mail could have arrived on Monday, on Tuesday, on Wednesday, wherever, but you only check it on Friday. So the FDA actually reanalyzed this and found that when you adjust for this confusion, the supposed 1.1 month benefit in PFS actually shrank to as little as only 5 days, which is, again, for a drug that costs 15, maybe 17,000 per month is crazy, and it doesn't even improve survival. The second analysis was about missing patients. So I said about 20 docetaxel patients drop out early on day 1, on time 0, even before any treatment was administered. So we can assume several things. What if those 20 patients had better outcomes than the rest of the docetaxel patients that underwent the whole trial? If we do an analysis with that assumption, actually the PFS advantage disappears. So an analogy, it's like a class where 5 students skip the exam. If you assume they failed, the average of the class drops. But if you assume they all get an A, the average rises. So ignoring those 20 is not honest. And the next one is about tipping point. The FDA asked, still about these missing patients, how much better would those missing patients need to do for Sotorasib's PFS benefit to vanish? And after, some calculations, turns out it only needs 50% of those 20 patients to do better for all the PFS benefit to vanish, to dissipate. So you can understand. So 50% of 20 patients is just 10. So a different result in 10 patients, in 10 samples, could flip the result of the trial entirely. And if it had done that, the drug might not have been approved anywhere. So, it's... And the next thing is about scanning read. So investigators selectively reread scans, actually. And mostly it happened in the docetaxel arm. So before rereads, results were not significant. And suddenly they were. So it's like you double checking, but you're only double checking it more in the docetaxel arm. Maybe the first time you read it, oh, it's not a progression. But you then reread it and you decide, oh, actually, it's a progression. Sounds unfair. And finally, it's about crossover adjustments. If we adjust for the crossover problems that I talked about earlier and apply multiple models, actually none showed survival benefit. So what does this all mean? So for patients, a 1.1 month delay in tumor growth without living longer, honestly speaking, I think it's not meaningful. When median survival is, around a year, we knew that already in this population. You don't need a surrogate endpoint. You can just wait and see the 12 months, the 1 year for survival, and to see whether patients live longer or die sooner. People care about time they are alive, not just whether, the tumor on my scan grows 30%, 31%, oh, it stays stable on 10% size. No, that's not that. And for the price and its benefit, I don't think any health system in the world could sustain this. Compare the cost to docetaxel, which maybe cost like a couple of hundreds dollars per month. And maybe even cheaper in other countries other than the USA. So for science, this trial is a case study about in how design choices, outdated comparator, crossover, open label, sample shrinkage can tilt the game and leave the central question unanswered. So here's my take. Sotorasib is a scientific milestone. I have to say that. And I admit that. It was amazing and it proves KRAS can be drugged scientifically. But clinically, the trial that seeks for its approval to be used in human, the Codebreak 200, was a disappointment. It's like finally building a bridge across a river, right? But the bridge only goes halfway. People will still fall in. It is progress, but it's not enough. And this is why critical thinking matters. During training, we learn to follow instructions, but once we graduate, again, every choice becomes our responsibility. You don't need to be at, once again, prestigious institution, have your tons of publications in prestigious journals, having high H index, to actually be concerned about things like this and understand about things like this. It's something that you can learn, you can study. You just need bravery and curiosity to ask, does this study prove what it claims? Does this treatment really help my patient live longer or better? And again, because it's approved, there are lots of doctors out there prescribing this drug, right? And I think those practitioners are divided into several categories. The first, people who prescribe the drug but are not aware of the study weaknesses. The second, people who know the weaknesses of the study but still want to be obedient in the system, because it's approved, it's being recommended by the guidelines, by your institution, place where you work, so they just follow the rules, quote unquote. And the third and the worst one, I think, is those people who know but do not care and still prescribe the drug. I think it is fair to ask those people who still prescribe this drug to answer to all of these weaknesses of the study. And if they cannot, well, something that I always ponder about. And that's why every GP, every resident, every attending, we must stay sharp, stay critical, and keep asking why. Because our patients deserve nothing less. And that's all for today. Once again, thank you for listening, for tuning in. I'm Diaza Arianto, medical doctor and cancer biologist. See you on the next episode.